Erling is going to talk about. He has an extensive talk. He was kind enough to tell me that he wants this presentation to be relaxed. He wants to give you the courtesy of interrupting him, asking questions. So please feel free to do that, and I'm sure he's going to tell you.
Okay.
Erling?
Yeah, it's my privilege to try to present a consensus document where there has not always been so much consensus, but a lot of discussion and divergent opinion. But as Mort told you, now I'll try to give you this presentation of where we stand now. We have not finished. We have not reached the end of our mission. But this is where we stand now. And please feel free to interrupt if you have some questions or comments. I'm going to try to present this new paradigm in risk assessment in coronary artery disease. I have no conflict of interest. My strength is probably the last. It's my limitations. So I am allowed to ask stupid questions because, in fact, I don't know so much about imaging, statistics, prediction tools, or cost-effectiveness analysis. So I have asked a lot of questions. I don't understand all the answers I have received, but now I will just try to present what I think is a consensus of this task force group. It started more than a year ago with this paper in circulation, October 2003, a call for new definition and risk assessment strategies. And it is said that available screening and diagnostic methods are insufficient to identify the victims before the event occurs. And it is the fact. Many of you know this paper from JAMA 2003, where it was shown that the major risk factor for ischemic heart disease account for the disease. Nearly all persons that have a heart attack have at least one major risk factor for coronary artery disease. So these factors are causal. They cause the disease. Nevertheless, the problem is also people that don't have the disease have these risk factors. So, and it was also said in a letter in JAMA after this paper was printed, that the predictive value of these risk factors are low. You cannot find out, you cannot predict who are going to have a heart attack or who will not have a heart attack. It's also an analogy that has been mentioned several times. It was mentioned also in British Medical Journal by Wall some years ago. No one will question that smoking is a major risk factor for lung cancer. Nevertheless, if everyone in a certain population smoked 20 cigarettes a day, asking about cigarette consumption would not distinguish those who are more likely to develop lung cancer from those who are not. And it's the same with risk factors for cardiovascular disease. They are so prevalent that you cannot use them for prediction. And it was, in fact, that fact that was behind the polypill strategy introduced a few years ago. If you can't find the people who need treatment, then why not treat all? And they suggested that all about age 55 should be treated with this polypill to reduce risk factors for the disease. And it is a reason we cannot predict and we cannot use risk factors. It is because there is so huge an overlap between those who develop disease and those who do not develop disease. This curve here is the distribution of cholesterol for those who develop the disease, and this one is the distribution for those who do not develop the disease. And down here is for blood pressure. It's the same. There is a huge overlap. So in this intermediate range, and what Fuster also told us before, there is a large group here in the middle where you cannot predict. Only if blood pressure or cholesterol is very low, it says something, or very high, it says something. But most of us are in the intermediate range, and that range you cannot use risk factor for prediction. There's also, in the recent years and few months, been a lot of discussion about relative risk. It's used frequently in epidemiological study to show the strength of an association. It can be said by relative risk. And in fact, many of these markers that is used to predict ischemic heart disease present their data as relative risk. But in this paper published by Pieper last year, it was in fact said that a marker with an odds ratio as high as 3 is in fact a very poor classification tool. So even if there is a strong association indicated by the relative risk, it does not necessarily indicate that this marker can be used for risk stratification, finding the people that need treatment, separating them from those who do not need treatment. Again, it's shown here, large distribution overlap by a marker. Those who develop the disease here, the solid line. Those who do not develop the disease, broken line. There is an odds ratio of 3. There's huge overlap. You cannot use this marker for prediction. So what we know today, and I think we can agree on that, in principle, most heart attack is preventable. We know what causes heart attack. We have causal risk factors. However, heart attack remains the #1 killer in Western society, including the United States. So I think it's fair to say that this traditional approach has failed. It's still and remain the major killer. So I think we can ask, do we need another approach? Can we do it differently? And can we do it better than just counting risk factor, going into table, finding a score, and we cannot use a score because we cannot predict in many of these patients. So again, going back in history, going from the vulnerable plaque, it started by vulnerable plaque, to now where we are today, the vulnerable patients. The vulnerable plaque was described in part 1 of these 3 papers. Number 3 will come. In part 2, the vulnerable plaque and vulnerable myocardium was described in the same month in Circulation a week later. And there's been a lot of discussion. I don't believe so much in vulnerable myocardium in primary prevention. I think the vulnerable myocardium frequently in ischemic heart disease come after you have myocardial damage. And I think more probably agree on that. At least I received this email from you just a few days ago where you agreed that probably vulnerable myocardium and also vulnerable blood play a more important role after a heart attack or during a heart attack rather than in primary prevention. But there may be 2 situations where vulnerable blood and vulnerable myocardium could play a role in primary prevention. In diabetes and the metabolic syndrome, we know there is an increased platelet activation, there is high fibrinogen level and high plasminogen activator inhibitor. And it could contribute to thrombus formation if a plaque rupture. So in diabetes, the vulnerable blood could play an additional role on top of the disease. And in hypertension, maybe a hypertrophic myocardium could play a role in sudden death and could explain some cases of sudden death in primary prevention in left ventricular hypertrophy. So diabetes and left ventricular hypertrophy could be states where vulnerable blood and vulnerable myocardium play a role in primary prevention. In this report, we have written now, Huang Battimon has written a paper on the vulnerable blood and some polymorphism in markers of the thrombotic component of the blood, but there is no really good marker that can be used in primary prevention for prediction. And we have also a paper here by Dr. Rudy that has written about non-invasive assessment of vulnerable myocardium, but again, it is probably not today very effective to identify vulnerable myocardium in primary prevention. So now we have reached the vulnerable patient. And the vulnerable patient is defined here as a patient at high risk, how high, of a near-term event. What is meant by near-term? It's the way we define a vulnerable patient. Again, we know that these risk factors are causal. Again, this paper published in Lancet last year, the Interheart study, studying a case control study from every inhabited countries in the continent on this globe, showing again that the major risk factors account for the great majority of heart attack, 90% in men and 94% in women. But why are they useless for prediction? Probably because the individual susceptibility to these risk factors vary. And there is also some protective factor we don't know so much about. Just to illustrate the difference between risk factors for the disease and susceptibility to the disease. Many of you have seen this before. I have it from John Romberger, Sir Winston Churchill. He died 91 years old, not of a heart attack, while Jim Fixx died of a heart attack 53 years old. I could imagine there was no major difference in risk factors, or they don't necessarily need to be any major difference in risk factor. It could just be because Jim Fixx was more susceptible for this disease, while Churchill has strong arteries. He was not susceptible to these risk factors. And it was we miss in our risk assessment today. It is the susceptibility to the disease. We are only measuring risk factors for the disease. So a group met half a year ago in Santa Monica. Some of them are here. And we discussed how to proceed with the identification of the vulnerable patients. And again, a lot of discussion, a lot of emails. Here one from Mort in February this year. I think the discussion was out of, you needed to direct the discussion again, I think. So we said, let's not forget the most important question, the short-term prediction, you call short-term less than 5 years, in search of the vulnerable patients. You don't define in this email the vulnerable patient, but I know what you mean with a vulnerable patient. So again, the approach today, it is in risk assessment. It is based on risk factors. It's office-based, and you calculate whether the person is in low or lower risk of having a heart attack, not in near term, but during the next 10 years, intermediate risk or high risk, also called coronary heart disease or coronary heart disease risk equivalent. In fact, there is only a factor 2 difference between people that already have the disease or are in the same level of risk as though we today call lower risk. A factor 2 in scoring. And we learned before by paper study that even a relative risk of 3 will not be able to separate those who are going to have the disease from those who will not have the disease. So our risk assessment tool we are using, in principle, they are not able to risk stratify the population. So we suggest that we do it differently. We are not measuring primarily risk factors for the disease. We are trying to assess the susceptibility for the disease. In our search for the vulnerable patients, it's only very few out here, but it's what's keeping us going. It is the search for the few out there who need immediately and intense treatment. But in our search for the vulnerable patients, in fact, we have a lot of information about the patients or about the individual. So we are able to risk stratify the whole population in those who have the disease, more or less of the disease. They are more or less susceptible for the disease. We'll find those who don't have the disease and are not at risk of having a heart attack. And we will start by defining a very low-risk group. We don't need to screen in our search for the vulnerable patients. And here we have the conceptual flowchart that come out from all these talks and all this discussion. Our search for the vulnerable patients. What is a vulnerable patient? Risk of a heart attack in the near future, within the next 5 years. And Mort would say we would like a high-risk patients with a risk for a heart attack in the next year for about 10%. It's a very high risk. It's in fact the same risk that we see in patients the first year after an acute coronary syndrome. This one is the risk of a recurrent event. And now we would like to find people in primary prevention without any symptoms with the same level of risk. I don't know if we are able to do it, but it is our goal. And we could discuss later which kind of tool, and probably Mort will tell us what we can do to find these person in primary prevention with that high level of risk of having a heart attack, 10% within the next year. I don't think we have the tool, but I agree with you. It is our goal. The best marker for susceptibility for the disease, it is to having the disease. And the more disease you have, the higher risk. And it is in fact already in the established guideline. For the NCEP guidelines say, if you have peripheral artery disease, if you have the disease in the femoral arteries, if you have the disease in the carotid artery, if you have an aneurysm in the abdominal aorta, you have a coronary heart disease risk equivalent. You have the same risk as if you have the disease in your coronary artery. So it's a concept that is well established, that the best marker for susceptibility is prevalent disease. But what we use today, it is not prevalent arterial disease, it is prevalent clinical disease. But now we have the tool to be able, some of us believe we have the tool, to be able to identify the disease itself before giving rise to clinical syndrome. So we now can extend this same concept by susceptibility, by going to the disease itself in the vessel wall, evaluate the disease, how much disease is there, and base our risk assessment on the amount of the disease. It is just an extension of what we already are doing now, because we have the ability to identify the disease. We have many different tools we can use today: ultrasound, MR, CT, compliance measurements, endothelial dysfunction measurements. Some of them have been used longer than others. Some of them have been used for many years, and there is some clinical outcome data. So we can say something more of some of these tools. There's ability to predict a clinical outcome. We can come back to these tools later. So now I would like to go through this flowchart in a stepwise fashion. And if you have any questions or comments, please say something. First, yes, Jay.